TRX-103 is an off-shelf allogeneic CD4 T cells. We call them also third-party cells that are collected from three healthy donors and infected with lentivirus system to transduce cells with IL-10 and delta NGFR. Um, the IL-10 will give the cell the TR1 cell property, while delta NGFR will help with tracking. So the goal here is to provide T-regulatory based approach to help improve the immune reconstitution after transplant. Based on the data that we presented in Tandem 2026, we saw significant accelerated immune reconstitution of donor-derived CD4 T cells. Those will reach higher levels compared to historical control that we already published in City of Hope data. This was also the same for FOXP3 T regulatory cells. And then, we also saw increase in number of circulating tolerogenic dendritic cells. We call them DC10, which usually express CD14 and CD16 in parallel to the natural TR1 cells increased. The prompt increase, reached the level that we see in even healthy donor early, in the 42 days post-transplant. We think the combination of donor-derived DC10, FOXP3, and natural TR1 Treg cells are usually important to tolerizing environment and improve the outcome of transplant.
When we first started brainstorming this project, our initial goal was actually to compare and contrast the outcomes between patients that are younger and receive Liso-cel compared to those that are over the age of 50 and receive Liso-cel. And the idea really came out of an interest in a niche of oncology and transplantation medicine of adolescent young adults, or also known as AYA. And the reason is, the AYA population, or even those that are a little bit older, but not truly of geriatric age, they don't fit neatly into a box. Especially those that are between the ages of 18 and 25, where it's unclear, should these patients be treated on a pediatric clinical trial or an adult clinical trial? Should they be in pediatric hospitals or adult hospitals? Also, do they respond differently to therapies, and do they experience adverse effects at different rates compared to older patients, not just within the general population, but like you mentioned, between the real world and the clinical trial setting. So when you're looking at these AYA patients, you can then expand these latter points to patients not just only on the younger age of the spectrum, but also in those that are less than 50, and then compare that to older patients. So keeping that in mind, we also wanted to know if there's a discrepancy between patient characteristics and those that are enrolled in a clinical trial that receive Liso-cel versus those in the real world setting. So this was basically a good opportunity to see if there are age-related differences, but also are there trial-related differences versus those that may be receiving Liso-cel as a standard of care or as part of a clinical trial at respective institutions. What's interesting is that, we didn't really see a statistical significant difference between the two groups. Both demonstrated that 12-month PFS rates were over 50%. However, when you did look at the 12-month and 18-month duration of response, while the results weren't statistically significant, there was a trend for a higher proportion of patients less than 50 who had a durable or a lasting response at 12 and 18 months. So, I would say the take-home point is that in the younger patients with relapsed refractory large B-cell lymphoma who are less than 50 years old and they receive Liso-cel, real-world and clinical trial settings both demonstrate that responses were deep and durable after treatment, which is similar to outcomes in overall populations. ICANS and CRS were the main toxicities that we were interested in, but we also looked at other rates of other toxicities like severe infections, prolonged cytopenias, and secondary lymphomas. And what we saw was that both were similar between younger patients and the overall population, as well as in the real world and the clinical trial settings. Our next step is going to be to look in more detail if there's difference in patient groups and other adverse effects like HLH, need for ICU admission, and any organ toxicity or dysfunction to further determine if there are two differences in the toxicity profile between younger and older patients. And to answer your questions in terms of how to mitigate those side effects, it's usually using standard of care, whether it's immunosuppressants or immune modulators like anakinra or tocilizumab, antimicrobials. Those are all things that we're going to look into on a more granular level to see if there's any difference between both clinical trial, real world, patients younger than 50, as well as the overall population.
Yes, absolutely. And I think, if we're able to look at a patient who's in remission with this therapy, certainly one of their bigger risks as we're continuing to follow them is infectious complications. And that is, can largely be a consequence of the chemotherapy that they received along with the CAR T-cell treatment and then any prior therapy prior to receiving the CAR infusion. And so the way that we do that at our center is by really closely monitoring patients, specifically looking at their immunoglobulin levels. We now have some data stemming from other groups that looks at in doing IVIG supplementation in patients with immunoglobulin levels less than 400, so trying to boost their immunity. And additionally, we closely monitor at our center their CD4 counts and use that in order to sort of gauge how long to continue them on prophylactic medications like acyclovir and PJP prophylaxis in order to reduce their risk of the complications. And it's kind of a tiered approach based on how their immune system recovers and comes back online of when we would discontinue or pull back on some of those supportive care measures. Yeah, so those exhausted CAR T markers can certainly give us an understanding that these CAR T cells may be not as robust in terms of their ability to kill the cancer cells or even persist in the patient. And I think persistence is one of the important things for follicular being a more indolent disease. And we have seen, if we look at especially some of the CAR transgene levels in the ALAR presentation, where patients did have longer persistence of their CAR T cells that was associated with continuing to remain in response. And so I think that being able to potentially limit things on the front side of exposure to other cytotoxic agents like bendamustine, which can be associated with impairing T cell function, and better selecting when to institute CAR T cell therapy can potentially get around some of these issues that we're dealing with where the CAR T cells can become exhausted.
Thank you. So those are all the questions that I have for you, but is there anything else about this study that you would like to add before we close?
I think this is an important landmark point for CAR T cell therapy, specifically in follicular lymphoma. We have already mature data presented from Axi-cel Liso-cel, and now this is the T-Gen-like Liso-cel experience. And I think collectively this, and even in combination with the Liso-cel data, which is only 3 years mature now, suggests that CAR T cell therapy is very active in follicular lymphoma, and I would argue should be more heavily incorporated in that disease.
So for the first question, no, we have not seen any data at this point to suggest that the durability of response to either Liso-cel or Axi-cel is different. So at a certain time point, 6 months, 1 year, 2 years, a certain proportion of patients, a vast majority of patients after 1 year in particular, hold on to their response. So if they're in complete remission at 1 year, regardless of whether you use Axi-cel or Liso-cel, they should remain there. So PFS differences between the two should not really exist after that time point. I would not expect the curves to separate at all. In terms of, do you need the expansion? That is a really good question. We don't know whether the higher level of expansion, like the peak, versus the area under the curve, so a higher level of expansion, but for a longer period of time, is more important. I think there's only theories out there right now. The way that I think about it is biologically effective dose, meaning that it's a cell to effector target ratio. And that means that, say, for example, this is not the case, but say you need 1 CAR T cell to kill 1 lymphoma cell. It's always an amount of CAR T per disease burden. So patients with higher disease burden need higher expansion. They need increased area under the curve. That's longer, more extended killing from the CAR-Ts, whereas patients with lower disease burden need less of that. So I think expansion is critical, but Axi-cel has a higher peak expansion, but it's shorter. Liso-cel has a lower peak expansion, but it lasts longer. We don't know whether one of those is more or less important at this time.